Dr. Kenneth Hughes, a Los Angeles plastic surgeon, board certified, Harvard trained, discussing your concerns about buttock augmentation. Butt augmentation has really increased in the past decade or so as far as the number of procedures performed, both in the Brazilian butt lift and in the butt implant procedures. Unfortunately, it has also increased quite dramatically in the number of illegal silicone and other filler injections as well. Dr. Hughes is spending a lot of his time removing a lot of these silicone disasters, which lead to tissue death, infection, fluid collection, skin changes, and innumerable other cosmetic deformities, as well as systemic health complaints. The silicone injections and other filler injections should always be avoided. There may be some small role for filler, such as Sculptra or something else that is FDA approved for very small volumetric improvements in things such as dents, but the full augmentation is not going to be accomplished by fillers. For the two treatments that remain, that include the butt implants and the Brazilian butt lift, Dr. Hughes performs a great number of those procedures each year. The two procedures are distinguished by the manner in which the surgeries are executed, obviously, and also in the relative frequency of postoperative complications, as well as the expectations of long-term durable change. The Brazilian butt lift involves liposuctioning various areas of the body, including abdomen, sides, lower back, upper back, bra rolls, anterior axilla, posterior axilla, submental areas on the face, areas of the neck, arms, inner thighs, outer thighs, posterior thighs, medial knee, areas above the knee, calves, ankles, almost anywhere you can find fat, this can be utilized for the liposuction portion. The liposuction fat then is collected, and that fat is then transferred to the areas of the buttock. The shape is largely determined by the volume injected, the relative skin tightness that the patient has, and the starting patient anatomy. The fat can be transferred virtually anywhere to the buttock to try to correct various dents, deformities, and things of that nature, as well as increase the buttock projection and also to improve the hourglass physique. This is done in conjunction with liposuction or liposculpturing of surrounding areas to heighten this improvement. The issues with patient expectations and relative improvement are far too complicated to discuss in our short video, but the main issues with the procedure include fluid collection on the abdomen, lack of results with the fat transfer after about 50% of the fat is basically taken away by the body after blood supply does not form. There are risks with fat necrosis, which is very small, but it does happen, where the fat dies and the fat then needs to be removed in some cases. The issue of the fat embolus has largely been a thing of the past now that no one is injecting into the muscle. That was an unexpected complication that no one knew about prior to several years ago when we instituted a change among plastic surgeon protocol. At this time, everyone should be injecting under the skin, which is reducing the risk for that complication significantly. I have not seen one since switching to that method. I cannot speak for other surgeons. And with regard to the butt implant, this involves placement of solid silicone implants. They can be round or oval shaped. They vary from about 100 cc's to 715 cc's. 100 cc implants will just not affect a large or drastic enough change for most patients. So this implant amount is usually between about 300 and obviously the largest 715. The main complications with the butt implant are fluid collection, the implant needing to be removed due to the fluid collection, incision opening, bleeding, and infection. Although nerve injury has been reported, this seems to not be an issue and seems to be more of a transient concern with the swelling. The number one thing by far is the risk for fluid collection, incision not healing, and the removal of the implants. This is directly involved with certain patient healing characteristics, but also the size of the implant. Patients who want very large implants are going to have to realize that the percentage that heals, despite optimal management by the surgeon, is not 100%. It's not close. It may, although the literature is vague on this and the literature doesn't report these large implants, we know that implants above 350 have much higher complication rates. So when you're doubling that volume to 700, you can anticipate complication rates and problems with healing in the neighborhood of 20 to 25%. This doesn't mean that all of these have to be taken out, but it may necessitate additional drainage, may necessitate scar revision, may necessitate, exchange of implants. All of these things are complications that patients need to understand, and they're really not even complications. They're eventualities of pushing someone's body beyond, what it is capable of handling. And that goes the same for surgery as in athletics, as in any walk of life. So it's important to be reasonable and realistic and adhere to and heed doctors' recommendations and instructions. The butt implant surgeries are typically performed by very few individuals. Dr. Hughes performs a lot of revisions. A lot of the previous surgeons either perform the surgery to place very conservatively sized implants, which is good in the sense that you won't have complications. The problem is you're guaranteeing the patient one or two more surgeries to get to the optimal volume. There is a rationale, however, for staging the procedures. For instance, if a person has aspirations of having a huge buttock implant, I frequently recommend that an implant that may not fit for a patient or is unreasonable, that the patient start at a smaller volume. Like, for instance, if a patient wants a 700 or 600 implant, I tell them that the patient can certainly start at this, the smaller volume and then kind of upsize as the tissues expand and things of that nature. I think that what happens is the foreign body responses can be very, very dramatic in certain people, just like there's exuberant scar formation in certain people, issues with keloids, issues with hypertrophic scars. Healing is always variable, and certain people can't heal as well as others for whatever reason, and that may not have anything to do with the surgery per se. So some of the time it does make sense to recommend a smaller implant. If a patient wants a 700cc implant, and that is just not reasonable for most patients. Now, even if the implant can be placed appropriately, there's still higher risk for that implant failing, which is something I always tell patients, which is why I tell them to pick a smaller implant. But let's say a patient wants a 700cc implant. It may be far smarter to place a 450cc implant, let the capsule form, let the scar tissue stabilize, let the tissue stretch, and then when you come back in to place a larger implant, there's a much higher success rate for those larger implants in the pockets that have already been created. So that's another option to avoid some of the butt implant complications if a patient is willing to cooperate in this scenario.